afternoon. I'm Dixie Woolston. I'm a clinical lifespan neuropsychologist, and I work at Mayo Clinic Arizona. I am currently serving as our division chair of neuropsychology and the chair of our neurobehavioral health team. I started implementing computerized testing in 2013 when I was working in a large private neurology practice in Texas called Texas Neurology. Due to some family circumstances, I switched jobs and ended up moving to Wyoming, which, for those of you who don't know, Wyoming is geographically huge, but very small in terms of people. There's more cows there than people. And the people in Wyoming did not have access to neurology providers. And so I started with my boss at the time, we started experimenting with telemedicine platforms. This was all pre-pandemic, and we were able to successfully set up telemedicine in Wyoming. This served me well when I switched to Mayo Clinic in 2019. I wanted to bring computerized cognitive testing and telemedicine to Mayo. But this was pre-pandemic, and believe it or not, Mayo administrators were having a lot of trouble understanding that the Zoom platform could be HIPAA compliant when used in healthcare. And I had to convince them that they were a decade or so behind in terms of not offering computerized assessments outside of concussion. There were many obstacles, as Mayo is a large organization with many logistical hoops and challenges, but finally in February 2020, just prior to the COVID pandemic, I successfully obtained the approval to use computerized testing paradigms at Mayo Clinic. And this allowed us to remain open when Mayo Clinic closed its doors to outpatients, as we were able to function seeing patients virtually via Zoom and by utilizing computerized testing paradigms. So during the height of COVID, we used the computerized testing paradigms to remotely assess patients that were COVID positive recovering in the ICU. Post the pandemic, we continue to utilize computerized cognitive testing in our remote video visits. We also use it in our pain rehabilitation center. And some physicians are using it to look for pre-post medication or intervention changes. I'm hoping to discuss with you different computerized testing paradigms available so that you can think about how to integrate computerized testing in your own research or perhaps your clinical practice. So I am a believer that brain, not pain, should be our fifth vital sign. So why should brain be considered a vital sign? Why should very busy, time-compressed doctors in clinical practice get a cognitive pulse at initial and perhaps annual visits? Perhaps the very greatest reason is that undetected cognitive dysfunction is associated with greater morbidity and mortality. Patients that are cognitively impaired but not demented have a mortality rate of 1.869 times that of seniors, and seniors with dementia have a 3.362 times greater mortality rate than people who are cognitively intact. The Mayo Clinic study of aging found that mortality was elevated in patients with MCI, or mild cognitive impairment, and this was higher for patients that had non-amnestic MCI, so where their cognitive impairment was not impacting memory. Mortality varied by sex, education, history of heart disease, and exercise engagement. Mortality rates were highest in MCI cases who were men, who did not exercise, had heart disease, and had higher education. So prevention of heart disease, exercise vigilance, these lifestyle changes can reduce mortality risk. Delayed MCI diagnosis is also very common in people who have higher education, and this can impact mortality as well. Also, cognitive illnesses such as dementia and Alzheimer's disease cost billions of dollars annually. This means that dementia is costlier to the nation than either heart disease or cancer. The average total cost for the last 5 years, this is in the United States, for a patient with dementia was $287,000, according to another study. And this is significantly greater than heart disease, cancer, and all other diseases on average. So a number of studies also show that cognitive impairment is unrecognized in 27 to 81% of affected patients in primary care. And this also might extend to other areas of medicine as well. These patients may have started at a higher level, which makes their decline more difficult to identify. One study showed that physicians were actually unaware of cognitive impairment in more than 40%, which is almost half of their cognitively impaired patients. Another study found that half of patients with dementia had not received a clinical cognitive evaluation by a physician. These numbers really help me argue the case that cognition should be considered a vital sign. Research also reveals that informal observation alone by a physician is not sufficient. Observation needs to be done with a specific cognitive evaluation tool. So the use of a brief structured cognitive assessment tool correctly classifies people with dementia or mild cognitive impairment more often than spontaneous detection by a patient's own physician. 83% if they use the tool versus 59% without it. So getting a cognitive pulse or a baseline is mission critical for our people. So the benefits of a timely cognitive impairment diagnosis include you can treat reversible conditions. You can assist with relapse prevention. You can introduce cognitive enhancing meds. And this is even more important now in the United States with the introduction of medications like lecanemab for Alzheimer's disease, because there's a small window when the person is cognitively able to actually have that disease, at least in the United States. It has to be at the very mild end of their dementia spectrum. Also, cognitive assessment can help enhance functional competence. And it can help both the patient and the physician contribute meaningfully to the treatment plan. The patient still has capacity earlier on when cognitive impairment is identified and can assist with sort of the plan for the worst case scenario. There are four main goals of cognitive screening. One is to establish that baseline. This is especially critical in people that maybe have a higher education level or higher cognitive functioning to start with. If someone has very superior cognitive functioning, they fall to superior, even high average. If all you saw was the high average time point, you would be unaware that they had had, a fall of almost 2 standard deviations. So getting that baseline, I think, is critical to correctly identify when someone is experiencing cognitive decline. Also, it can establish the need, whether further assessment is necessary. And certainly a cognitive pulse at an annual visit can help individuals who have not yet sought medical attention for their cognitive problems, who are maybe just saying, well, this is normal. Everybody my age is looking for words or can't remember what they had for breakfast yesterday. This also, a cognitive screen can help us really closely track someone's response to different treatment modalities. So I really like Alan Turing, and he developed in the movie Enigma a very quick test to identify who he thought was smart enough to help him crack Enigma. I'm just going to show this short clip. And it's not playing audio. Anyway, this woman in the clip, she solves the problem in 6.5 minutes, which impresses Alan Turing, and he eventually uses her to help on the Enigma team. So I wish that in neuropsychology we had the ideal screening test of something that was 6.5 minutes, like Alan Turing developed, but unfortunately we have not yet been able to do that. An ideal screen should be brief. especially in the United States, many of our primary care physicians have 20 minutes or less with their patients. So they are really unable to do something like a MOCA or even an MMSE if that takes up 15 minutes of their visit time. It needs to be well tolerated. It needs to be easy to administer, to score, to interpret. Ideally, we'd like something that was bias-free and culture sensitive. We would also like it to be sensitive to a wide range of cognitive dysfunction and to tap many abilities, not just one domain, and to be useful when we're looking at changes across time. Psychometric considerations to consider when trying to figure out what cognitive screen to use. One is the normative sample, and this basically means all the details on who the test was tried out on. What country was that normative sample data collected in? Hopefully, as we have this more global reach, the goal really is for normative samples to reflect many cultures, many countries, many levels of education. One example I have is the MOCA was developed in Canada, and when we did a large-scale study in the Dallas Heart Studies, we realized that the Canadian cutoff of 26 was actually a bit high for our Texas, Dallas heart study folks. And so the normative sample really can make a difference in terms of interpreting your test and understanding your test. Was your sample well educated? Does the average education match your clinical population? What about age ranges? If you want a test that's sensitive to dementia or mild cognitive impairment, then you want the test to include generous data on older adults. If my client is African American, Latino, or in Arizona, I see many Native American Indian people, I want to know, is there normal data available on these demographic groups? Does the cutoff scores change if my individual is not Caucasian? Gold standard is for the normative sample to match the latest census data in terms of percentages of your race, your gender, your age, and your education levels. Another feature that's very important for cognitive testing is reliability. And in the Matrix, if any of you have seen the Matrix, you'll remember that the computer developer shows a lady in red to Keanu Reeves's character, and the lady in red totally distracts Keanu Reeves during the video clip. And basically, the lady in red was known to have 100% reliability because every single person who underwent the trial matrix training got distracted by the lady in red. So really, in an ideal world, our test would have 100% reliability. So that is the extent to which repeated measurements yield consistent results. The standard for cognitive testing should be 0.80. So whatever screen that you end up using, try to look for that standard. If it's used for decision making, such as maybe dementia placement in a nursing home or IQ placement in terms of people getting into gifted classes, then that standard really should be higher. It should be closer to 0.90. Validity is what does the test measure? How well does it measure it? You really want your shots in the center of the target. So you're really looking for D in terms of a valid test. You want all of those shots right where they should be. In C, the shots are reliable but not valid. They're consistently in that part of the target, but they're not hitting the bullseye or the center of the target. So in terms of validity, very few coefficients actually exceed 0.60. So really, we're looking for 0.5 to 0.6 in terms of a test validity. And we are looking for either sensitivity or specificity. So sensitivity is how well does your test capture patients that actually have the disease? So for example, with Alzheimer's disease, How well does your test capture those patients that have been diagnosed with Alzheimer's disease? And specificity is, does the test reject people that are truly negative? Can you exclude those based off of your test? Some pros and cons of using a computerized testing paradigm. One of the pros is definitely the cost and time savings. The computer is 100% accurate, usually with response recording, as long as there's no data glitch. As opposed to typically we might use pen and paper methods that might be someone recording responses. They might not be as accurate as the computer. Obviously, another big plus of computers is just the automated data storage and being able to compare easily across time points. And then a computerized administration is always going to be standardized. It's not quite true when you have a person doing it. And people with limited training, so your MAs, your nurses, a technician, they can actually help with the administration of a computerized measure, whereas face-to-face, you need more specialized training and have to invest time in training your people on how to administer these things. Many of the computerized platforms now are adaptive, so if the patient, depending on how they score, it can either get harder or easier. And that can also help shorten the test as well. And you eliminate all the need for hand scoring, so the results are available immediately. And many of the computerized platforms have alternate forms that are statistically reliable available, which is a big plus over the pencil paper traditional methods. However, there are definitely some cons. Many of the computerized paradigms out there have very few people in their normative samples, maybe just a few hundred. We really ideally, like I mentioned earlier, we're looking for more global normative samples, and from each country, we would hope to have more in the thousands versus just a few hundred people. Sometimes computerized testing does not meet the psychometric standards of reliability and validity. Many patients don't like, especially on the older end of the spectrum, they dislike a computerized interface. And right now, there's not really a gold standard evidence-based consensus paper out there of what we should be using for computerized testing. In the United States, there's also been some issues with reimbursement with computerized testing. Insurance companies tend to like the face-to-face better, and so it's sometimes reimbursed at a much higher level than a computerized test. One of the platforms that I like that we use at Mayo Clinic that's out there is called CNS Vital Signs. And it's a computerized screen. It takes about 35 minutes, so it is a little bit time intensive. However, we utilize it at Mayo Clinic by sending the patient a link. They complete it at home, so it doesn't actually take time in your visit to go over. CNS Vital Signs has multiple statistically equivalent forms, so that makes it very amenable to repeated assessments. So it's very good to be used pre or post a treatment. So for example, we might use it in MS patients who, before they start a disease modifying agent, and then we can assess their response a month, 6 months later. The other thing I really like about CNS Vital Signs, it's available in many languages. So 60 languages, it's very good for global use. And it's actually been used in 52 countries. You can tell from the screen, it's really easy to interpret. If you're green, you're great. Yellow is still on the normal range, but kind of a caution color. We like to watch things that are in yellow. Orange is a mildly impaired problem, and red is much more moderate to severe. So it's very easy for lay people or a primary care physician to get the gist of. And in my experience, the memory testing is sensitive to a mild cognitive impairment or perhaps an emerging Alzheimer's disease. And so I think it easily helps me target patients that might need further in-depth testing. This is just an example of a patient that was well, they were on Topamax is the first, the far part of your screen. And then when they came off Topamax, you can tell that their cognition improved. So this is just an example of how we use it in the clinic. The other thing I really like about CNS vital signs is it has a lot of behavioral rating skills available. So for example, the one that's on your screen is something called the Neuropsych questionnaire. I like it because it's very short. It takes people usually between 3 to 5 minutes to complete, but it gives me information on pain, sleep, fatigue, a lot of psychological variables such as depression and anxiety. And then it also lets me know what the patient thinks about their memory and attention. So I feel like I get a lot of information from one measure, but it also has many depression, anxiety options. It has scales for brain injury, like the concussion scales. It's got attention measures, sleep measures. You can add all of those easily into your administration if there's a particular variable you're interested in. With the executive population I mentioned yesterday, that group has a tendency, because of the nature of their jobs, they are frequently in social situations and tend to overdo it on alcohol. So we were easily able to add the audit to our battery of screens for them to really get a more objective sense of their alcohol use. Another platform that's out there is called NeuroTrax. And one of its strengths is it does measure a variety of cognitive issues. And the other thing that NeuroTrax does is it really tries to provide the patients and the provider with some individualized recommendations based on the results that are based on evidence-based principles. So that those are pluses of NeuroTrax. It's not as widely used as CNS vital signs. It doesn't have multiple forms. And the testing time is more 50 minutes. So it takes quite a bit longer to complete. The NIH Toolbox is another computerized platform that's out there. And basically cognition is one of 4 domains that's measured by this. So the other domains are motor function, sensation, and emotion. And so how the NIH Toolbox was developed was they used expert panels and they came up with cognitive domains that they identified as the most important for health, success in school and work, and independence in daily functioning. And so those domains that they identified are executive function, episodic memory, language, processing speed, working memory, and attention. And so they created 7 measures that are designed to tap those constructs. And the instruments, they only have 476 in their normative sample from the ages of 3 to 85. And that's kind of the basics of the NIH Toolbox platform. It's being much more widely used in many research and clinics. The CANS MCI was only identified 3 domains that they wanted to use. That's executive functions, memory, and symbol fluency. And the age ranges for this, because it's mild cognitive impairment, was 68 to 84. So the only comment I have on it is the discriminant validity was really determined by comparing normals to very outdated neuropsychological tests. The CAM-C is another measure, and the last measure I'll mention. It runs on a tablet. It only has 1 form. The cognitive domains, unlike the other measures that I've talked about, were not empirically derived. And so It does purport to measure attention, executive functions, memory, and word recall. And one of the unique features of this measure is the second part has more of a virtual reality test. It asks the individual to go through a virtual world and purchase groceries. And so that's a unique functional piece that most of the other tests lack. However, it's only normed on 296 people, and the cognition was normal cognition is defined as scoring higher than 1 standard deviation. And so, however, it does purport to be very sensitive to MCI at 86% with a specificity of 94%. So those are just some examples of the computerized testing. And I hope that you will consider in your own practice whether there's a role of using cognition as a 5th vital sign. Thank you very much.